So good morning, everybody. Welcome to our Cardio Echo QI series. Exciting to see all of you again. I hope you all had an enjoyable and restful holiday season. If you had to work, thank you for working. I know I worked most of the season, so not everybody gets to take time off. So anyway, next slide. So I think everybody's seen this slide multiple times. I'm not going to spend a lot of time on it, but this is who Cardio is. We were founded in 2017 to improve cardiovascular disease and health outcomes and to eliminate disparities in Ohio's Medicaid population. Next slide. This is our agenda. I'm going to be talking for about the first 20 minutes. Then I'll turn it over to Gotham, who will go over the clinical pearl and the case discussion. Amanda will facilitate the report outs, and then Andy will talk about next steps and wrapping us up. So these are the 6 sites that are participating. Once again, thank you all so much. We're excited to have you here. And here's your project leadership team. I think you know all of us at this point. We have no disclosures. If you want CME and you're not receiving it, please contact Kathy Sullivan. Once you opt in, you'll get an email so you can get your CME credits. And then we can also offer maintenance of certification. If you're interested, please reach out to Andy. And please do not share PHI. All right, so today we're going to talk about a topic that I love, running control charts. So thank you for bearing with me while I geek out with you on this moment of how we look at data. So the objectives for today are going to be to list and describe the aspects of run and control charts, describe strategies for using runs and control charts in QI work, and describe the application of one or more of the preceding tools to individual QI projects. So why do we use run and control charts? So first of all, we're using the model of improvement to do our QI work for this project. So the first question we always ask is, what are we trying to accomplish, or what is our aim? How will we know that a change is an improvement, or what are we going to measure? And what change can we make that will result in an improvement, or what is our intervention? So a run chart really helps us understand how processes are performing by making them more visible. It determines whether or not a change has resulted in an improvement and whether or not we're sustaining our gains. Next slide. So this is the element of a run chart. So the median is the black center line. The green line is your process measure. The x-axis is time. And then the y-axis is your measure. Next slide. So there's 4 rules that we generally apply to run charts that indicate there's a non-random pattern. So the first is a shift, which is 6 or more points above or below the median. And this indicates a dramatic change in the process. The second rule is a trend, and we're going to show you pictures of this so you don't have to remember all of this, which is 5 or more points up or down, and they can cross the median line, and indicates a non-random pattern. An astronomical point is a data point that is blatantly different from all the other points in the chart. And something I'm not going to spend a lot of time on is too many or too few runs, but too many runs can signify that too many or too few runs can just signify that your process isn't stable. Too many indicates that there may be, non-random patterns, and that you may need to do some more investigation, and same with the too few runs. So the next slide, Andy, shows 3 of those rules. The first one is a shift, so 6 or 8 points above or below the median. The second rule is a trend, 5 or more points up or down, and this can cross the median. And then an astronomical data point is 1 point that is really different from all of the other data points. Any questions? Okay, next slide. So now we're going to get into whether or not you can interpret the rules of a run and control chart based on the very brief explanation that I just gave. So you can chat in your answer. So if you look at this particular process, has there been a meaningful improvement? You can unmute too, it's a small group. So
Where's the median?
good question. We did not put it in here. That's a great question. We need to fix this slide. Probably all of these slides, Oscar. So Austin says he can't tell. You want to elaborate, Austin?
I can. Can you hear me at all? I've got all
Oh
type
no.
of chat. I've lost my voice because I'm one of the cold people that everybody has. So I'll type in, but basically I can't see what there's no other data to tell me are we zoomed in here? Are we zoomed way out? Just like you said, what's the median? What's the time frame? What are the indices here?
Great, good question. Any other thoughts on this one? Does anybody think there's been a meaningful improvement or not?
I think that.
Sorry.
Go ahead.
Go ahead, Amber.
Oh, I was thinking, I don't think so because it seems like there's too many runs.
Jim, did you want to say something?
Yeah, I totally agree that you can't draw conclusions on this one because you can't seem to find where the median is because of the graph that looks like a jigsaw pattern. So
Right.
yeah, it's difficult. Yeah.
So if you look at this, do you see any runs one way or the other? Like if you had to imagine where the median might be, do you see any runs or do you any sort of trends? Well, in the interest of time, Andy, let's go to the next slide so we can show the answer. There has been no improvement. Here's the median. It has a lot of variation, but no consistent trend towards improvement or towards a worsening process. Let's go to the next case. So if you look at this one, has there been a meaningful improvement? Orson's shaking his head.
The trend is going down.
Yes. So if the goal was to decrease some type of number or behavior, then yes.
Okay, so if you look at where the change was actually made, is anybody going to change their answer? All right, next slide, Andy. So in this case, we would say that there hasn't been a meaningful improvement because the improvement started before the change was made. So while there has been an improvement, the improvement was already occurring before any sort of team implemented an intervention. Does that make sense to folks? Thank you, Orson.
Yes.
I'm not sure who said that, but thank you. Thanks, Amber. All right, next slide. All right, has there been a meaningful improvement?
I think only very, very slight in reference to start and finish.
Can you expand on that, Jim?
Because if you look at the data point at the start and then looking at the data point at the last part, so the last part is that data point is slightly lower compared to the start. So although you see the trend, it has risen up and then it has fallen down and then it has risen up again. So having looked at that trend, there may be a very, very small change, but we don't know what the confidence interval of that one is. So if the confidence interval overlaps between those 2 points, then there may not be any significant improvement for that matter.
Oh, Jim, you're jumping way ahead. We do talk about confidence intervals when we get to control charts. We don't have confidence intervals in run charts. So actually, the confidence intervals are what we refer to as control limits, and they can shift. So, but we will talk about that in a minute. Any other thoughts on case number 3?
This is Bhaskar. It seems like there is a trend towards recovery late in the data collection.
So maybe there started to be an improvement and then it wasn't sustained. Correct. Is that what you're trying to say?
No, I'm saying that there may have been some sort of an intervention which was activated late in the process, and we see a trend towards recovery, which is the last four data collection points.
Well, you're making a good point, Bhaskar. So we don't know if the desired direction is up or down, right? So
No,
so you're assuming that in this particular control chart that the desired direction is up.
or towards recovery.
Yeah.
Let's put it that way.
So next slide, Andy. So we would say that there was an initial improvement, assuming, as Bhaskar has pointed out, that the desired direction is down, but then the process goes back towards its original behavior. That could be a good thing or a bad thing, depending on what our metric is, right? So if we're talking about hemoglobin A1C, we want to see it go down, right? The percentage of patients with uncontrolled A1C, we want to see that go down. And we don't want to see it go back up again. All right, next slide, Andy. All right. Case number 4, has there been a meaningful improvement? Any thoughts here?
I think there is, because looking at the last, the halfway through the graph, it was able to sustain. It was able to sustain that trend right there. So if you draw a line on that median right there in reference to the starting point, so you will see that change.
Any other thoughts here? So
I
Jim,
think
go ahead, Amber.
that there was some changes, but they weren't sustained. So I think too many runs.
Okay. So Jim, going back to you, you think that the change has been sustained, right? But when the change was made, my question to you is, what do you think was going on before the change was made?
So again, it depends on the metrics that we're trying to measure. Let's say, for example, we're trying to determine the pattern of HbA1c. So initially it was elevated, and then it became more elevated, and then let's say, for example, with treatment, the A1c dropped down and then went up and then dropped down, and then with some variability in the trend. So if, again, depending on the metrics that we're looking at, so that's how I see it.
Okay, so let's step back for a minute. Let's say the metric doesn't matter, okay?
Mhm.
And you see that the change was made where the change was made, right? My question to you is, was the process improving or was the process changing before the change was made, if you just look at the data points?
Say that again. Was the
Was the
process
process changing before this team made the change? You can see where the change was made, where that blue arrow was.
Yeah, I mean, I think so.
Good. All right. Next slide, Andy.
Yep.
Yes.
It's only 4 points down.
Right.
Mm.
So apparently everybody's taking what I shared before very, very literally, which is great. But this is just like if you're just looking at it empirically and just looking at the data points, was there a change? In this case, there was an improvement, but it had started earlier before the change was made, which is what we just talked about. Next slide, Andy. All right. Has there been a meaningful improvement?
No, that's an astronomically high point.
Correct. Next slide, Andy. We're running out of time, so yes. So that's what we refer to as special cause variation. And it's a stable process with just 1 point. So maybe depending on when it was, maybe somebody was out of the office or on vacation, maybe a patient, there's a small number, some patients no-showed, who knows what it could possibly be. But we all agree that there's this is an astronomical data point. All right, next slide. Okay, has there been a meaningful improvement? I think I scared Jim from answering.
I'll let the others answer.
Any thoughts?
Yes, I think there was a meaningful improvement.
Great. Next slide. Yes, you can see that they made a change. The team made a change. We don't know what the change was. It doesn't really matter for this, but there was a meaningful shift in, the downward direction. So that's a very high level of how you interpret run charts. I'm not going to spend a lot of time on control charts for the sole purpose of this project. There's really not enough data to do control charts, but if we could go to the next slide, Andy. So really, a control chart is very similar to a run chart. It helps you track processes or outcomes over time, distinguish between normal variation and true change. We use it for a variety of healthcare measures, and it really tells us whether our system is improving, worsening, or staying the same. Next slide. It helps us identify real changes, when to act. It shows the impact on QI efforts and PDSA cycles. It helps you really understand across your team what's going on and really supports data-driven decisions. So the components are similar. There's data points, but instead of a median, we use a median. And then we have an upper control limit or a lower control limit, as Jim pointed out earlier. Those are defined by standard deviations. And then a lot of times we annotate our control charts so we understand where the intervention has occurred, so we can understand why a change may or may not have occurred. Next slide. So it helps us understand common cause variation or day-to-day fluctuations, which is expected really in any stable system. It does not mean the system has changed. Special cause variation could be a real change or a significant change, could indicate an improvement or a problem, and will require investigation or action. Next slide. So the rules are similar: 8 common points above, or 8 points above or below the mean, 6 points trending upward or downward. I think we lost the D there somehow. 1 point outside the control limits, which could be special cause or is special cause. It could be an astronomical point, but it doesn't have to be. A sudden shift in the data pattern. And this all indicates that a system has changed for the better or worse. Next slide. This is just an example from another project that some of us are involved in. You can see the red arrow under the cardio logo that indicates the desired direction is trending downward. This is actually like trending for A1C. So we want to reduce the number of uncontrolled patients with A1C. You can see if you look in like between October and January at the very beginning that there was a trend towards improvement, and then if you look in April, there was a shift in an undesirable direction. But then we were able to improve that shift between, it looks like, about January and April of 2024, where you see a shift in a desirable direction, which caused the change in the mean to go down, right? And then you can see where we started annotating our interventions. So this was increasing GLP-1 prescribing and utilization for patients with uncontrolled diabetes, identifying barriers to prescribing GLP-1s, more focused prescribing on GLP-1s, and then finally, towards the end of the control chart, you can see we've started to focus on timely follow-up. So this is just an example. We probably won't be using these for this particular project, but if you have questions about run or control charts, your coach can definitely help you. Feel free to reach out to any of the leadership team. We can definitely help you with run and control charts. And I think at this point, are there any questions before I turn it back over to Gautam? Okay, Gautam. Oh, sorry, one more slide, Gautam. So here's the key differences. I'm not going to go over it because we're out of time, but you can see the differences between the run and control charts and where to use each. And you have access to these slides, but once again, feel free to reach out if there's questions. And a reminder that quality improvement is not a linear process, so you will see fluctuations that may or may not be special cause. So just keep that in mind. And if you do see changes trending or shifting in an undesirable direction, that's when you investigate. You don't panic. You just start to think about, what may be occurring with your particular process. And now I think I'm turning it over to Gotham. Sorry about that, Gotham.
That's fine. Thank you, Aleece. That was a great overview. And I hope you guys have an opportunity to apply run charts at the very least to some of your QI efforts. So switching gears completely, now we're going to talk about a clinical issue that's come up in my own practice and probably in yours over the last several years. So let's consider Janice. She's a 55-year-old woman, longstanding type 2 diabetes and obesity. You start her on empagliflozin. I'm going to try to avoid using the trade name here. Initially at 10 milligrams daily, and then you raised it because you got a good response in terms of control over type 2 diabetes. Remember that you prescribe SGLT2 inhibitors and GLP-1s independently of hemoglobin A1C, even though we generally do prescribe them to improve control because they've been shown to reduce heart failure admissions, et cetera, and cardiovascular events broadly. They are generally recommended. So she began the medication 4 months ago. Since that time, in just 4 months, she's had 3 vaginal yeast infections. She hadn't had one in the 10 years prior to starting the medication. She had had type 2 diabetes for about 10 years. So in that entire 10-year period where she had type 2 diabetes and was not on an SGLT2 inhibitor, she had no yeast infections whatsoever. I'm really curious as to seeing how you guys would handle this issue now, because I will get up on my soapbox in a couple of minutes, but before I do that, I want to see what you guys would do.
So I would, looking at this case, I would tell the patient, or even before starting this medication with the patient, I would have given this patient a heads up about the possible side effects of this medication. So as you know, as the case goes, so this could be a possible side effect of the medication. So I'm gonna solicit her idea about, because of this vaginal yeast infection. So I'm going to present options about, okay, so this is how we treat the vaginal yeast infection. But if it continues to be a trend, so we are going to go with A option, B, C option. So in relation to this medication, if it's not really sustainable, then we may have to shift you to another medication. At least that's what I thought.
Okay, thank you, Jim. Very, very wise advice. Anyone else?
I would agree with Jeff.
You agree with Jim, Amber? Is that what you said? Okay.
Yes, Jim, sorry. Yes.
Here's the thing. So what is recommended is that you treat her vaginal yeast infections one after another in sequence, as you would in any woman in these circumstances. And you remind her that the benefits of the SGLT2 inhibitor greatly outweigh the risk of vaginal yeast infections. All true stuff. My concern, and this is guidance from the FDA, obviously the drug manufacturer. Also, there was a guideline from Europe, and this is exactly what you're supposed to do. Just go ahead and treat. This is not the Fournier's gangrene, which is a life-threatening perennial infection that can lead to sepsis and death. That's a different issue, and that's extremely rare. But these routine vaginal yeast infections, this is the approach they recommend. My concern with that approach over the last several years I've been prescribing these is that some of these women will just stop the medication. I was getting too many yeast infections. You may have heard that already. So then what are you supposed to do? So you're following the expert advice, the consensus statements, etc. Just keep treating. She'll have another one in a couple months. Just keep treating. And at a certain point, this becomes intolerable for her. And she says, well, this isn't working for me. I'm getting all these infections. You say my control is improved. She may not feel that much better on it. I just stopped it because I couldn't handle anymore. So here's what I've been doing. I talked to the makers of this medication. I'm not going to name it, but or similar ones. They're all pretty similar in terms of the risk of vaginal yeast infections. Is to stop for a little while, re-challenge her with a lower dose of empagliflozin. So she was on 25 milligrams. Stop for 2 or 3 weeks and say, let's start you at 10 and see if we have the problem again. In my experience, that has been acceptable to patients. When you say to a lady, oh, don't worry about the vaginal yeast infections. I've never had a vaginal yeast infection. What do I know, right? Basically. So you just keep taking it and we'll treat them as we go along. That is something that comes from research scientists, etc. I don't think that's great practical advice. I think you have to have a better strategy than that. Of course, it's going to be shared decision making, and Jim was getting at that. Here's what could happen. If this happens, here are some options. We can treat it. If it keeps happening, we can continue to treat it, or we can try discontinuing for a while and re-challenging you, or as Jim said, maybe we can try something different. But you have to present those options. Just continuing, I think, is not acceptable. So any additional comments about that?
Hey, Gotham.
Yeah.
So we all know the vaginal yeast infections go up big time with the SGLTs. In my humble practice, it seems like I see the same thing with UTIs.
Yeah.
And it seems like they're even less concerned about the UTIs as they are with the guidance for the yeast infections. Would you follow the same sort of thing if she had 4 UTIs in the last 3 months?
Absolutely. If this woman had 4 UTIs in a 4-month period and she'd not had one before, now let's assume she's completely menopausal. Okay, that's not an issue here. Yeah, absolutely. I'd follow the same advice for that too. But what I think is that my key lesson here is this is a human being. She's a woman. She's got real concerns. Just to follow the guideline-based advice to continue treating her, because from a risk-benefit standpoint, it's better to continue. It doesn't make sense because she may discontinue on her own. So we want her diabetes to control. We want her to get the benefit of this medication while mitigating the risks. A great point.
This is Jenny Gilmore. I totally agree with you. I've done clinical research on these medications for years, and we did the initial trials and everything, and we did see all these side effects.
Yeah.
I think bringing the patient in and having them have a say makes them more compliant, and we saw that too. So I like your idea. It's not discontinuing the med completely, but it's giving them a chance to say, hey, I'm having these problems, listen to me, and we'll work together. And I think that's a really great way of doing it without just getting rid of the med completely.
Absolutely. Thank you, Jenny. Yeah, and I think this is an example where guideline-based care can sometimes undermine overall quality. So even though, and I've been on I'm actually on the CKM committee for the American Heart Associations. We don't address this issue in particular, but a lot of the folks on those committees are not clinicians, or if they are clinicians, they do not actually see patients regularly, and they don't take these realistic, real-world considerations into their recommendations. Next slide, please, Andy.
Gautam, before we move,
yeah.
Do we need to assess how much this medication is contributing to the control of diabetes? I mean, if it's contributing minimally, then maybe it can be discontinued.
Yeah, absolutely. That's a good question. So we often will start these to improve control, even though there are other benefits. Vascular, we can have, the cardiovascular benefit, etc. That having been said, let's say she has hemoglobin A1C of 7, and I put her on this medication, it goes down to 6.8. I would be more inclined to stop it as well if it's really not making a big difference for her. A great point. Okay, Andy reminds me we've just got a few minutes to talk about this case study. And again, the same sort of theme, diabetes, newer medications. So Isaacson Family Medicine is in Dayton. It's associated with the Wright State, is interested in improving prescription of newer diabetes medications for patients with uncontrolled diabetes. So we've had some similar projects here at UH here in Cleveland. The idea is that, well, actually, nobody on this call, but we have a project right now funded by the AHA to get older patients off of sulfonylurea drugs, which are really, really bad. Of course, lead to hypoglycemia, falls. Most of my patients are older African Americans. A huge proportion have type 2 diabetes. A huge proportion are on these drugs, which are cheap. They've been taking them for 30 years. They're used to it, and they do fall, and they do suffer the consequences. And so, within our project, and within the this population and the broader population of patients with diabetes, we are trying to change that, because these drugs now, the SGLT2s and the GLP-1s, have been around for more than 10 years, and yet a small proportion of patients are taking them. Okay, and there are many reasons for it. So let's say we do an audit at this urban practice in Dayton. It reveals just 10% of patients with diabetes, type 2 diabetes, have been prescribed a GLP-1 or SGLT2. How might you start addressing the problem? Where would you start trying to change this dynamic?
Oscar, again, prescriber level, I think we need to find out why they're not being prescribed these drugs. That would be the first step. And of course, then initiate some changes, which may include some type of education or data presentation to the staff.
Mm-hmm. That is excellent. The wrong approach would be to say, we have a QI effort, we're going to measure you on your SGLT2 and GLP-1 prescription rates and hope that there is an improvement over time. And here's a presentation on the benefits of these drugs, which I'm guessing most of these providers are already aware of. The why is the critical thing that you can do. You don't have to do a formal survey, but this is a small practice, right? Let's say there's only 6 providers. Why don't you ask them? And what barriers do you think that you would encounter if you did that?
So, Dr. Rao, the very common barrier, because I prescribe these medications to my patients, see, the very common barrier that I encounter is that the insurance approval is because the insurance companies makes us jump through hoops. And even if there is a strong indication of this patient has diabetes, and along with that, because of these patients are overweight, so they benefit from it at the same time. But then the insurance companies, I don't know, take it the wrong way, in the sense that our primary target in prescribing this medication is because of the overweight. They overlook the main purpose, and it's really a headache when we deal with that kind of issue.
And I think, Jim, that's probably the number one barrier that I have faced as well. Incidentally, Trulicity, I think, was available through Medicaid without a prior authorization. However, I've heard and this may be a rumor, but just as of recently, that has changed as well. So, but anyway, the barriers are significant, whether the patient have a Medicaid plan or not, because of insurance. The other barriers are that patients are accustomed to taking their usual, metformin and glyburide, maybe a little insulin at night. That's an old regimen that they take. And I think a lot of them are not, if they don't take insulin, they're uncomfortable with injections as well. But there's no question that insurance is a significant barrier. And if you talk to the prescribers, they know their patients, they know their insurance, they're not going to bother with it. Okay. So if you were to design a project around this, and I know that a lot of projects are just consideration. You have a little care gap if you use Epic that pops up and say, did you consider a GLP-1 or an SGLT2 in this patient? If you considered it and you decided it wasn't right for them, that's okay. But at least you're considering it. You're presenting that option to them. So what outcome would be meaningful in a QI effort? Probably not hemoglobin A1C, right? But what would be a useful process outcome?
What I can think of an outcome in relation to these medications is the outcome of I mean, speaking in the context of other effects, like for example in heart failure, because these medications can be used also in heart failure, so it will reduce their admission, their frequency of admission or exacerbation of heart failure tantamount to hospital admission. So that's what I'm looking at.
Yeah, so I think that's a long-term outcome. I would actually back up a lot from that, because we're at a point, and you've pointed this out, Jim, as of others, that insurance is a huge barrier. Hey, maybe look and see if they've even tried to submit a prior authorization, right? For how many prior authorizations have been put through, even if they're denied, right? Or if there is a discussion, or if you have a care gap that comes up, did I click on it and say, yes, I thought about it, I wasn't able to, yes, I thought about it, I have. But I wouldn't necessarily look long-term outcomes. That would be wonderful if they did. It is a shame that these medications are so effective from a cardiovascular standpoint, and we still face barriers 10 years after their availability, hopefully fewer and fewer as the years go on. But that would be the sort of thing. The wrong approach, I think, would be just to say, hey, Dr. Torrevillas, you need to improve your rate of prescription. You're at 23%. We need you up at 40%. It's like, well, wait a second. That is a misunderstanding of clinical practice. And I hope that both this and the clinical pearl kind of get you thinking about more practical ways to implement QI as well. Any final thoughts about the case before I turn things over to Amanda? Okay, thank you so much, Amanda.
Thank you. Good morning, everyone. I'm looking forward to getting your updates on your QI projects. We're going to be talking really today more about your holiday report outs and sort of how you've been able to maintain QI and what that's looked like through the holiday season. So we'll go to the next slide. Looks like Jem, you're up first. If you want to just kind of talk through the questions and sort of how you navigated through the holidays.
Yeah, so good morning, Amanda. So this is the answer to that. So this is what we formulated. So we didn't do anything out of the ordinary, because every patient encounter is a chance to review the labs, medications, and comorbidities. We're still communicating with the front desk regarding scheduling, medication refills, and repeat labs and follow-ups as well. And then the barriers that we have encountered is because, of course, it's the winter season. So a lot of people have been affected by respiratory illness, and because of inclement weather conditions, there were some cancellations along the way in relation to the holiday season. And the last part of that question is, how do your team adapt or problem solve to address these barriers and the key lessons? So we call them, and we call them because when we anticipate their appointment, when we anticipate the discussions that we're going to make with these patients, they didn't show up. So we took upon ourselves to call them and say, hey, you were supposed to have, we were supposed to discuss this, and I understand that you missed the appointment. So moving forward, if you can kindly reschedule so that we can, or you can have your labs taken, or we can adjust your medication. So those are the things those are the steps that we had to take in relation to this issue during the holidays.
So did you call patients that didn't show up for the appointments, or did you proactively call patients?
No, we looked at the schedule, the projected schedule for the week, and then of course, like in all honesty, I have patients wherein I need to see them because I need to recheck their BNP because their potassium is this or that. And along with it, this other medications that I need to speak to them about also. So I had to call uh, one or two of my patients with regards to that issue because again, although LDL or lipid panel may not be a laboratory parameter that's critical, other laboratory parameters like the serum potassium or other electrolytes is very critical in a sense that you only have a very uh, the wiggle room for that one is only very narrow. So yes, I had to call them.
That's awesome. I think that's great. I think, we all can relate to how we get off our schedules and our normal routines during the holidays. So, providing that extra support and that extra layer of, almost being like a cheerleader to the patients and keeping them on track is great. So kudos to you guys for proactively doing that.
Thank you.
You're welcome. Anything else, Jim, or does anyone have any questions for Jim? All right. Well, thank you.
Sure.
I don't think we have Arpita on from Metro. So we can go ahead and go on to Fisher-Titus. David, do you want to talk to us how you have navigated through the holidays and be able to continue your QI work and support patients?
Good morning, everybody.
Morning.
Morning. Initially, what we did was we started about December 15th, and we started flagging alerts in the charts of the patients that we need to ensure get seen. So if they are to call in to try to change an appointment or to cancel, we strongly encourage them to go ahead and make that appointment or reschedule that appointment. So we wanted to make it available to everybody to see that, yes, this patient is a part of the QI project, and we wanted to make sure that they got scheduled. Some of our barriers during this time, weather is a huge one for us, especially with some of the distances that we have patients in this practice traveling and our age group. So if the weather, even they talk about it being bad, a lot of those patients will not come. So we did adapt some of that as well as calling the patients if we had to. And things that we are going to carry forward. We have been using chart alerts for other things. We are going to carry it forward for a lot of these issues so that the biggest portion is when a patient calls to reschedule or to cancel an appointment, we want that alert in there so the folks at our front desk know that this person needs to reschedule within a certain time period. So the alerts have been our biggest thing that seem to help. But again, our holidays are a little bit slower, so we don't have the same amount of folks coming through. But that's what we tried.
I love that. So you really use that flag in the EHR for two different reasons, really to alert the provider, hey, this patient needs that follow-up. Then also the front desk can use it if a patient cancels, they notice that alert's in there and that's a high-risk patient and really need to put some extra efforts in getting them rescheduled. So I think that really speaks to using those like high reliability interventions where you're allowing your EHR to really help drive the care. So that's really important.
And the alert also helps. We have a call center, so if that patient does call into the call center and doesn't get the office, those folks do get to see that alert as well.
That's fantastic. And I guess you did like an initial training for everyone just to really.
Everybody's already trained on doing this. We use it a lot for extended appointments for patients that are difficult or if there's a language barrier. So we already use it. We just adapted it for this purpose.
I see. Okay. And then for those patients that weren't able to make it because of distance or whether you were able to reach out and like at least connect with them on the phone and check.
Yeah, we did We did pretty well. Most patients will call us back just because a lot of them are they're once a year appointment or just coming in. And for whatever reason, the older folks do those appointments in December and January. You would think summer would be better, but yeah, they usually call in. If they don't, we do call them.
Great work. Any questions for David? All right. Well, thank you for sharing, David.
Thank you.
Let's see. Nicole, are you on from Erie County? Do you want to talk to us how you've navigated through the holidays with your QI work?
I hope everybody can hear me. I was having some issues with my laptop, so I had to call in instead.
We can hear you.
Okay, great. So processes or strategies that help our team sustain QI work during the holiday season. So the only days that we weren't here were New Year's Day and Christmas Day. So really our QI projects and our initiatives and what we were, had in place prior to the holidays just continued throughout that. Barriers or unexpected challenges we encountered. So I don't know about any other locations, but this flu bug that is going around is absolutely just taking our staff out. So there was about 2-week period that we had a lot of call-offs, so we had to make some adjustments to our schedule. So obviously that's going to impact, from a larger scale, just our operations, but also our QI projects too. So thankfully we're back on the mend. So I hope everybody else is staying well and staying healthy. But it's been crazy this year with that, especially around the holidays when everyone gets around each other and germs get spread. So hopefully we're on the better half of that. And then how did our team adapt or problem solve to address these barriers? When it came to that, we just continued to carry forward with the staff that we had. Patients still were coming in. We still had to operate. We were not going to cancel patients by any means when it came to that. So we made do with what we had and continued our QI initiatives.
So it sounds like that you had a lot of staffing challenges. I've heard that new flu variant is a pretty rough. So it sounds like you were dealing with that.
Yeah, it was going through our staff pretty rampant.
Oh my goodness. Anything you would do in the future to like maybe help plan for some of that, or anything you maybe would have done differently, or maybe that's not an option, that you just did the best you could do, but just didn't know.
Yeah, I think we just made do with what we had. It was what it was. And a lot of us have experienced staffing people through COVID, especially when that first hit and everyone was out for 14 days. So we always kind of compare it to it could be like that. So and that was terrible. So no, we make do with what we have. It just has put a little strain on us for a bit. So
well, I'm glad you all are on the mend and things are looking up. So thank you so much for sharing.
Thank you.
Amber, do you want to talk to us how you guys have been doing over there and navigating through the holidays at Village of Healing?
Similar to we got hit with the flu pretty hard. I was out, the nurse was out, so that interrupted our patient schedules quite a bit. I also had time scheduled at the end of the month, PTO scheduled. So we had been talking about ways to, empower the patient to be focused on their outcomes. And so we've been working very diligently to get patients like blood pressure cuffs and CGMs and different ways to monitor their blood sugars and blood pressures for some of our higher acute patients. So I'm thankful that our hard work kind of showed up for us in that way, because we were able to make phone calls to patients, checking in on them, having them do their blood pressure monitoring. And we learned that we were able, with those conversations, having a steady, that can also be a steady form of reimbursement from a chronic care monitoring process. Excuse me. So I think moving forward, we've even created like an SOP that we will be following these patients on a kind of consistent basis via phone call in between their chronic care appointments so that we are still pushing our goals. So it actually turned out pretty good.
So you feel like that pre-work and really having patients with that remote patient monitoring really helped to sustain during the holidays and help patients to feel empowered to continue the care through the holidays.
Yes, yes.
I wonder, Amber, did you guys talk any about perhaps maybe scheduling patients earlier in the year versus waiting until the end of the year? Or I just was curious if anything like that had come up in conversation.
Oh, as it relates to my vacation time, yes, absolutely. We were definitely focused on making sure, there weren't a lot of gaps in care, especially because a lot of patients, have FSAs and different things. So the end of the year, but we were having those conversations well in like September because we have a lot of like teachers and students who, when they have their time off for school, they try to jam pack their appointments in. So we were definitely keeping that in our thought process ahead of time.
Sure. Well, I'm glad that this work was able to set you up for success during the holidays and that you really were thinking about that earlier in the year and just making sure patients are supported. So great work.
Thank you.
Any questions for Amber? All right. Hearing none. So thinking about February and preparing for report outs, we thought, given the topic today of running control charts and that overview that Aleece shared with us today, that we could maybe take the time to dig in a little bit more to some of our data. So we thought maybe putting together a process measure data slide. We'll have each practice do that, and I can certainly work with you all on which process measure we want to share. But maybe just discussing like what the data shows over time, how that data has supported your QI work, how the data has informed decisions, or how you've created your PDSAs based on that data. If you've noticed any special cause variation, we can maybe point that out and talk about what you noticed and what may have contributed to that special cause variation. And then just a couple reminders. We'll just use one data slide, one process measure we'll look at and discuss during that meeting. Really when I think about learning from the data, not having perfect results, but what are we learning from the data? How are we tweaking our QI projects? How are we changing our interventions based on the data? And then thinking about any challenges and lessons learned. It's always nice when you can talk about challenges and lessons learned so practices can learn from one another. So practices aren't making the same mistakes, or if you've noticed something that works really well, it's nice to share so practices can not have to reinvent the wheel and make those same mistakes, and can just take off running on their QI work from all the lessons you've already learned. And I think that's it for me. Andy, do you want to close this out?
Absolutely. Thank you, Amanda. So I'd like to give you all a heads up. We have our next cardio webinar coming up next month. You can register at cardio.org, and we are offering a free credit of CME. And then just some reminders, a post-clinic survey is emailed to you. Please complete that by next Friday. Your next round of data is due February 6th for January. And then Claire, did you want to give a shout out about the focus groups?
Yeah, so thank you for those of you who've responded to my email. We're trying to schedule focus groups with all of you to get some feedback with our data team. I have some of them scheduled, but some of them I've emailed reminders this morning. So Village of Healing in Erie County specifically, if you could check your email and respond back to schedule with us, that would be greatly appreciated.
Awesome. Thank you. And then just a reminder, our next clinic will be February 5th. We're back to our normal first Thursday of the month. And it'll be patient-driven tools for quality improvement. If you have any questions or concerns, feel free to reach out to any of us. And we're excited to see you next month.
Bye, everyone.